We have with us Dr. Sujatha Mohan. I'm sure many of the other expert panel can join in because we are going on to something which is so critical on a surgical plane. So she is again the additional director of Rajan Eye Care Hospital, a specialist in cataract, cornea and refractive surgery, an amazing surgeon who has performed innumerable eye transplants, and she is going to tell us in her very interesting video which has won awards how I would treat flap striae. On to you, Sujatha.
Are you able to see it?
No.
Okay. Now?
It's a blank screen.
Now you're getting it?
No. Would you stop sharing and share it again? We'll see. That time it came, no?
Yeah. Okay, I've got it now. I think. Are you getting it?
Oh, click and see.
I think we are coming on whiteboard. Because I think the whiteboard, Sujatha, the video is not sharing.
Okay. Not sharing.
Sujatha, you try once more. Otherwise, you. Now it's there.
Okay.
Yes, Sujatha. Go ahead.
Okay.
You have to play it.
Click.
Thank you,
Click on that.
for the opportunity. Yeah. And just the authors have no financial interest in any of the products mentioned in this video. Flap striae are defined as small wrinkles or fold in the cornea as a result of LASIK surgery. The most common classification of flap striae divides them broadly based on their size. Microstriae are microscopic superficial wrinkles that are generally asymptomatic and often only detectable on microscopic examination of the cornea. However, macrostriae are larger and full-thickness folds that usually cause noticeable visual impairment. The incidence of clinically significant striae requiring treatment is between 0.2 to 1.5%. The common causes of striae are thinner flaps, higher ablation depth, misalignment of flap after replacement, flap contraction and desiccation during ablation, flap wrinkling during stretching, movement of the flap on the first post-op day, tenting of corneal flap over an ablated stromal bed, a nasal versus a superior hinge, and excessive manipulation of the flap. Micro or macro striae not causing visual symptoms can be left alone. Flap folds such as this can cause severe visual symptoms and have to be dealt with immediately. Visual symptoms linked to striae include irregular astigmatism, optical aberrations, monocular diplopia, and degraded uncorrected visual acuity and best corrected visual acuity. Early intervention is recommended in these cases. In the first case, the pupil is dilated for a good transillumination effect on the striae. The flap margins are identified. The Sinskey hook is used to break the epithelium. The flap is lifted and floated on the bed. Two dry Merosal sponges are used to stretch the striae perpendicular to its direction. The stretching is done repeatedly till the visual axis is clear. Flap is replaced meticulously and a bandage contact lens is applied. The post-operative photo shows a clearing of the macrostriae with significant visual improvement. The second case presented on the third post-op day with flap slippage and flap folds. Here, the stromal bed is exposed with epithelial ingrowth. In this situation, the epithelium over the exposed bed is meticulously removed with a hockey stick knife before lifting the flap. The flap is lifted. The folds in the flap can be best addressed only by removal of epithelium on the surface. So the epithelium is completely removed on the flap surface as well. The flap folds are stretched using 2 dry merosal sponges. The bed is washed to remove epithelial nests. Flap is replaced and smoothened with a wet sponge. 4 11-0 nylon sutures and 1 10-0 nylon suture was applied to keep the flap in position. Then a bandage contact lens is placed. This case highlights the importance of preventing epithelial ingrowth in such situations. The post-operative picture shows a smooth flap with a good return of visual acuity. The third case shows a similar situation with a flat slippage with dense flap folds and epithelial ingrowth. A merosal sponge is used to completely remove all epithelium on the exposed stromal surface and a 2 mm margin around the flap. Flap is floated into position. The epithelium on the surface is also removed to facilitate the removal of striae. Stretching the striae is done using 2 dry merosal sponges perpendicular to the direction of the striae. Flap is replaced after completely washing the interface. Fourth case shows a completely displaced flap with rolled edges. This video shows the importance of removing epithelium under the surface of the flap in addition to the stromal bed. The rolled up flap edges are gently scraped off the epithelial ingrowth and replaced. Suturing the flap is mandatory in this situation to prevent repeat flap slippage and epithelial ingrowth. Femto flaps show less incidence of flap displacement and striae due to better fitting of the flap on the bed. However, this femto flap shows radiating flap striae originating from the hinge. The epithelium over the striae is removed after lifting the flap. The striae are stretched perpendicularly. The flap is replaced on the bed after thorough washing of the interface. The pre-placed marks show a significant shift after realignment of the flap. In cases with visually significant striae, early intervention, meticulous removal of epithelium from stroma, application of suture and bandage contact lens gives best results. Our series of patients improved with simple stretching of the striae using dry merosal sponges. In case of refractory striae, PTK and Donenfeld method of hyperthermic ironing of the flap using heated spatulas has also been recommended. Flap striae are better prevented than managed. Examination of the flap at 20 minutes post-operatively is recommended to ensure the flap has not slipped out of position. Careful and precise positioning intra-op is mandatory. Good counseling and need for adequate protection during day and night prevents and lowers the incidence of flap striae.
Thanks, Sujatha. That was a wonderful video, and I think it just explained it all, and amazing skills. Now I would take questions from the expert panel, and Sujatha, you could add on because you told it all. Have any of you, maybe Dr. Mahipal, I would ask, would you have thought of trying a PTK for flap striae? And if we were to do a PTK, theoretically, if we were to do it, how would we titrate the amount of epithelium removal? Would we take ASOCT guidance? And
anyway, thank you very much. I have never done a PTK for flat striae removal. I personally feel that the first thing is that if a patient is coming with visual symptoms, often we ignore the patient and say okay, there is nothing. It's always better to do a full dilatation and do a retroillumination to get these striae into play and to see as to how exactly these striae are, whether they are in the center or not. Recalculated striae, even managed, I have managed a similar bad striae like Sujata showed 1.5 years after the initial thing, having had a wash done elsewhere. The only important thing that I'm trying to re-emphasize what Sujata said is that epithelium needs to be removed. The other important thing which I think which maybe Dr. Sujata didn't emphasize is the use of hypoosmolar solution. So if you use this thing, that swells up the cornea and it is much easier for the striae to go off, and I fully agree with her regarding using two Merosol sponges. That will take care. But one important thing is that the striae on the table never disappear. Like you can, you will still see the striae there, but doing the hypotonic after removal of the epithelium and doing, you have to be very patient and you have to do it for a couple of minutes to be able to say as to what it is. PTK, obviously, I have never needed to do it because the striae go off. And another important thing that Dr. Sujata emphasized was that the incidence of epithelial ingrowth are much higher whenever you relift a flap, and specifically once the epithelium is denuded and you have swollen up the, obviously the flap gets swollen up. So at times, if it is very significant, I would prefer to apply a little bit of a glue and then put a bandage contact lens. So
And
these
also,
are the things, and epithelium, obviously you have to do an OCT to put it as to how much of epithelium you have to remove and then remove the striae. But doing a PTK with long striae doesn't really, it's not required actually. You will be able to.
actually, probably it does the work of manual epithelial debridement, which we do to a large extent. And I think also removing epithelium beyond the area of flap margin, which is suggested, is one more important point so that the epithelial ingrowth doesn't come in. Any of the other expert panel would like to add?
Can I say something?
Yes, Kumar.
So one thing, Sujata, excellent video. Only thing was that in today's era, we would like to do, if sometimes, these are referred patients, to do an OCT cornea to know the thickness of the flap. Because once you remove the epithelium, suppose you have a 90 micron flap and you have a 60 or 50 micron epithelium, you have a very, very thin flap. Then the whole game changes completely, and you have to be very, very careful when we are stretching with the two sponges. So as rightly said, the sponges, and as rightly said by Mahipal, but I feel that an OCT cornea would help us to know the thickness of the flap, and then we become a little more careful in such cases, because sometimes they are old operated cases, they come back and we really don't remember the thickness.
Swelling of the flap also definitely adds to it and is an advantage. That is why they keep saying to hydrate the flap. But have any of you ever done something as drastic as considering sacrificing a flap if there's really recalcitrant striae and crumpled flap, like after in some kind of a road traffic accident? Dr. Tityal or Dr. Namrata, have you all ever felt that you have
No, I shall be covering that topic towards the end,
Sir is going to show some of the very recalcitrant cases.
I think one point I'd like to add what Dr. Sujatha nicely showed. I'll remove the epithelium, debride the epithelium before lift the flap.
Yes.
If you lift the flap, then you try to do, and as Dr. Kumar is saying, that it becomes very difficult to remove the complete epithelium. So better to remove epithelium totally first, then lift the flap.
Yes. Very relevant point.
Just one point I want to make is excellent video, Sujata, emphasizing all points. Just that, debriding epithelium is extremely important, because sometimes when the striae has been there for some time, the epithelium tethers the striae. But occasionally you come across these flat striae on the first post-operative day, on the second post-operative day, when we see the patient immediately. In these cases, we can get away without even removing the epithelium, just hydrating the flap and stretching it perpendicular to the direction of the striae.
The first case I showed.
Yes.
Yeah.
Yes.
I completely agree.
Yeah, I agree. Any tips for flap suturing in these very thin flap? Namrata, you have anything to add for the?
I think I would rather glue them rather than suture them, because then you are not altering the contour of the flap at all, or the cornea. So it makes sense to glue them all around.
Can I just ask a question, ma'am?
Yes, Naga.
Yeah,
And
lovely videos, Dr. Sujatha ma'am. I just wanted to ask, what's the usual consensus? Like, because flaps striae are known to be more common in thinner flaps. So suppose you have a 90 micron flap, and on table you see that the moment you remove the speculum, there is a slight flap misalignment, and you put it back. Definitely, if there is a problem, then you put in a BCL. But do you put a BCL in all the cases where you have a 90 micron flap?
No, I wouldn't.
No, right? Yeah. Just wanted to.
Satyajit, you want to
Most
ask?
often we are making 90 micron flaps using a femtosecond laser.
Yes.
With the femtosecond laser, usually the incidence of flap striae, flap slippage is much less because the way it settles down is much better than a microkeratosis created.
So I think best is to go flapless.
I was waiting to hear that. But also, if you put any adrenergic, the risk of getting flap striae and flap, slippage is much more. So one has to avoid, putting even those small little, anything which contains phenylephrine or, that has to be totally avoided. And that's one of the causes. And second thing, I think most critical to avoid flap striae is to dry adequately, give enough time. Most often we finish in 15 seconds and then we are off the speculum. If you have to wait, ideally maybe 2 minutes is the time. But I don't think any of us waits 2 minutes.
Yeah. Thank you very much for the inputs. We shall now go on to